actually my job has been already made easy by Priyanka since she's covered most of what I was about to say. So I will not take too much time. Between you and lunch, I will try and finish in 10 to 15 minutes. So my talk is clinical applications of component resolved diagnostics. So my talk is clinical application of component resolved diagnosis or CRD, as Priyanka has just told in great detail. But I will only focus on the clinical applications. Sir, Dr. A.P. Singh. Sir, Bajo, A.P. Singh.
Silence, please. Dr. A.P. Singh.
It's a very short presentation, and then we can all meet and greet each other. So, we all know that allergy is on the rise. Priyanka showed that nearly 25% of India's population is sensitized with some form of the allergens. And we all know common symptoms are bronchial asthma, allergic rhinitis, dermatitis, urticaria, gastrointestinal symptoms, ocular allergies, and last but not the least, anaphylaxis. So, allergology or the branch of allergy diagnosis is in a mix of a technological revolution where both diagnostic and therapeutic capabilities are being drastically enhanced. Conventional testing modalities center around detecting Ig antibodies against the total extracts. For example, if I am detecting against apple extract or peanut extract or milk extract, so we were targeting the entire group as a whole earlier. But what has now happened with the advanced purification techniques and the molecular level analysis is that we are now pinpointing the protein fractions that are responsible. So if I am going to say that you have got allergy to say dust mite, I am not going to say dust mite. I am going to say that you have allergy to component DERP1, DERP2, DERP10, DERP23. And all these different subgroups will have a different clinical implication, different prognosis, and even different intervention for that matter. So, what was one considered as allergen is now known as an allergen source. And the real allergen is in the specific protein component and not the group as a whole. So, for example, if you look at dust mite, now dust mite earlier was an allergen, but now it is an allergen group. The specific allergen are DERP1, DERP2, DERP10, DERP23, so on and so forth for different allergy groups. So, unless I go into the detail, I am not going to have a customized tailor-made solution for every patient. Either you are going to give the patient with a cocktail of anti-allergics and steroids, or whatever immunotherapy that is available is very broad spectrum. Before you get into targeted immunotherapy, you first know what are the targets. So diagnostic level of Ig mediated allergy, the step one and the most important step is the clinical history and physical examination. Without this, you don't proceed at all because a lot of times these specific allergies, IgEs are present 5 to 10 years before the actual advent of symptoms. So you don't have to treat the test, you have to treat the patient. So first, you have to take a proper clinical history and physical examination, and only after you find the relevant symptoms, then you move down. So Priyanka told you about the two approaches, top down and bottom up, and you asked why bottom up should be preferred above top down. So we just briefly, we know top down is from level 1 to level 3, from skin prick test to the molecular testing, whereas in a bottom up you move from level 3 to level 1, from a molecular testing to a skin prick testing. So the whole algorithm is converted upside down, and most of the research papers that are coming now are putting more and more thrust, more and more emphasis on the bottom up approach, and there are good reasons for it. So what are the benefits of a bottom up approach? A, there are standardized capture allergens. What do you mean by standardized? So, from a crude extract that is home grown, when you move to a standardized format, you know, the report across my lab or another lab in Ahmedabad or Surat or Tamil Nadu should not be very different from each other because of the way we are doing our home grown technologies. It should be reproducible. Second, allergens are free from non-allergic components. So when you do a crude extract, both allergic and non-allergic molecules coexist. What happens sometimes is that some of the allergic components are masked by the non-allergic components. So what this leads to is when you're targeting each molecule separately, there is unmasking of the non-allergic components. Third, you can distinguish between genuine and cross sensitization. So whether an allergic sensitization is genuine or is it a cross sensitization because of the carbohydrate cross determinant that she described, CCD molecule, or it is a cross allergen between different molecules like dust mite, shrimps or cockroaches. So you are getting allergy across three components. But if that is from the tropomycin group, you know that some of these allergies are actually not genuine allergies, they are cross reactions. Then it will differentiate between clinically relevant and irrelevant antigens. So what I mean by clinically relevant, some of the allergens are minor allergens. They cause very minor symptoms, don't even need treatment. So it separates major allergens, minor allergens and pan allergens. So it has the ability to differentiate between clinically relevant and irrelevant allergens. It also provides prognostic viewpoint. Some of the allergic molecules have got a very high predisposition to certain diseases, like for example, the cat allergen to the asthma, or the mold allergen to the allergic bronchopulmonary aspergillosis, or for that matter, wheat to the exercise-induced anaphylaxis. So once you find those molecules, you can prognosticate your patient. If this can go into further trouble, so you can prognosticate better. You can of course differentiate true positive from false positive, because most of the false positive today are primarily because of the carbohydrate cross determinant which is present across virtually all the groups. Then of course, once your target is correct, your targeted therapy will also be correct. So immunotherapy success, which is currently rated at around 70%, once we start using this for more targeted therapies, the success rate of immunotherapy will also go up. It can predict severity of allergy. So severity of allergy is primarily dependent on two factors. One is whether the protein is heat stable or heat labile, and digestion stable or digestion labile. So the more heat stable, the more digestion stable the protein, the more severe allergy it can cause, because it will not be nullified by either eating the food or by digestion process in the gut of the human being. Second factor in the severity of allergy is the quantity of the allergen itself. So the higher the titer of the allergen, the more likely is the severity. So once we have a fully quantitative assay and we are targeting heat labile and heat stable molecules separately, we can predict the severity of the allergy. Of course, we can prevent CCD interference, I already told. Allergens that are susceptible to denaturation and digestion can be known, and if suppose a heat labile allergen or a digestion labile allergen is there, for example milk allergy only, if you have a heat labile protein that is you are allergic to, you can tell the patient ki doodh ko garam karke piyena, you can warm the milk. The allergen component will get destroyed and you can find to do with it. You can identify major allergens, you can identify minor allergens, and you can identify the pan allergens. Then you can analyze co-sensitization. Sometimes you could be allergic to more than one group simultaneously. And sometimes 1 plus 1 is not 2, it can be 3 also. There is an augmentational effect of two concomitant allergies coming together. You can avoid immunotherapy for minor allergen sensitization. So if for example, I am going to give you immunotherapy for dust mite and it is a minor allergen, it is an unnecessary immunotherapy. A, it will not work. B, you are unnecessarily putting the patient under tremendous economic burden and success being immediate. It can guide in direction of precision medicine. So like in oncology, we are now today living in a world of precision medicine. Unless we identify the targets, there cannot be no targeted medicine. So two patients with dust allergy or peanut allergy could have two very drastically different treatments based on the proteins that we have discovered. It can provide guidelines on patient management strategies. So this she's already shown that this is the allergen source, this is the extract. So if you look, these red, yellow and green dots here, they are specific allergens. And these blue dots here are cross allergens. So if you have this molecule which is allergic in peanut, you could simultaneously have cross allergy to apple and sugar cane. So that software will use the AI and say that look, these are cross allergens and you needn't worry about them. So different type of protein families are there, but I am particularly interested only in tropomycin because this is one family where a lot of cross sensitization happens between shrimp, dust mite and cockroach, very common. So a lot of vegetarian patients come to us, have got shrimp allergy, they have never eaten shrimp any time in their life, but they have very high G levels to pen and bun because of course they have dust mites in their house, they have cockroaches in their house. So the advantages of CRD is already covered, so I will not spend too much time on it. CCD induced false positive is not there. We use highly standardized protein, batch to batch allergen consistency there. So between two batches, I use a new batch of a reagent. It's not that I'm going to get drastically different results because of the standardization. Ability to provide prognostic information is there. Severity analysis we can do. Risk stratification we can do. We can distinguish between genuine and cross-reactive allergy. We can analyze persistent or remission of food allergy. So after giving, food withdrawal, the Ig level should come down. So remission can also be checked. Individual guidance for allergen avoidance can be there. Customized treatment. Reduces the need for oral food challenge test. Discrete criteria for immunotherapy patients. And we can effectively analyze complex allergic syndromes. This is already covered basically. I will not spend too much time on it. But broadly I want to say that within the same allergen group, you could have a molecule that could give you no clinical presentation, a molecule that could give you low probability of severe reactions, and a molecule that could give you high probability of severe reactions. So of course RiH2 is more heat stable than RiH8, hence this is there. So I told you about the severity reaction and the risk gradient. So as you move from here to here, from CCD to the storage proteins, the molecules become more heat stable, become more digestion resistant, and are present in large concentration. So the severity of the allergy from the carbohydrate cross determinants to the storage proteins increase in an exponential manner. So individualized avoidance, I'm giving you an example of egg. Suppose the protein is GALD1, which is the heat stable and a digestion stable protein. You need to avoid egg in all forms because it is not going to get corrected by even eating it. But if you have GALD1, GALD3, GALD4, GALD5, these are heat labile and digestion labile. So you can eat raw or semi-cooked eggs. So same allergen group, different management. Again coming to genuine versus cross-reactive, we already discussed this. This is the dust mite, shrimp and cockroach example. DERP10, black 7 and PEN-M1, very high cross-reactivity. So this is the algorithm of a dust mite which is very common amongst inhalation allergies. So if you get minor allergens, it could either be cross-reactivity. If you have DERP11, this is a marker for AD, DERP5, risk of asthma. But if you have major allergens like DERP1, DERP2, these are the fit candidates for autoimmune therapy. So if you are going to give immune therapy to these patients, it will not work, and B, it is unnecessarily going for it. Whereas if you give it for DERP1 and DERP2, this is a good candidate for autoimmune therapy. So immune therapy selection of candidates is much better once you go at the molecular level. Of course, prognosis. This CAT molecule has a very high predisposition of bronchial asthma. So if you find this in your allergy report, you can tell the patient that you have a high predisposition of bronchial asthma. If you find these molecules in the molds, this is a very high probability of bronchopulmonary aspergillosis, very high candidate. And if you find this tri-A19 in the wheat, this is a very high probability of food-dependent exercise-induced anaphylaxis. So we can prognosticate the patient based on the molecules. So this is the impact of CRD on diagnosis and therapy. This is for about 275 patients with respiratory allergy. In 58% patients there was no change. In 10% there was change in diagnosis but not change in therapy. But in 32% of the patients, based on CRD, there was both a change in diagnosis as well as a change in treatment also. Same for food allergy. This is on 187 patients of food allergy. In 18% patients there was no change. 44% patient diagnosis was changed but therapy remained the same. And in about 38% patients, both diagnosis and therapy was changed. So clinical benefits of component resolved diagnosis we've already done, so I'm not going to spend too much time on this. Now this is an article from the World Allergy Organization journal. This is actually a consensus document for molecular based allergies. So what they are saying is molecular allergy diagnosis allow for an increased accuracy in allergy diagnosis and prognosis and plays an important role in three key aspects of allergy diagnosis. A. Resolving genuine versus cross-reactive sensitization. B. Assessing selected cases of risk of severe systemic versus mild local reaction in food allergy. And last but not the least, identifying patients and triggering allergens for specific immunotherapy. So this is a consensus statement from the World Allergy Organization. And this is a relatively recent article from Billy in March 2021, where by Barber et al., this is from Spain. They say the use of molecular allergology for diagnostic purpose will rapidly evolve in the next years and will be more linked to the identification of patient phenotypes and endotypes for an improved therapeutic approach, which implies opening of the era of precision allergology. CRD today provides a good starting point. So with these words, I'd like to thank you. If there are any questions, I would like.